Okay, today I will be doing my inline suctioning comp. Before we get started with that, I just kind of want to go over my equipment real quick just to get that out of the way. I will have my Yonker, my cuff checker just in case, just gonna have it, my saline bullet, just for those thick secretions, some sterile water, I have my PEEP valve just in case, a mask just in case, a BVM bag with a capnography on top of it just in case an emergency happens, and it is hooked up to 100% oxygen right now, and it is running for that emergency if it happens. So first what I would do is get an order to inline suction this patient. I would check my order, make sure there's no contraindications, going over it. Gathering my equipment, which again is these things I pointed out right here. Gathering those up and bringing them with me. I would knock on the patient's door, come in, state my name. Hi, my name is Haley. I'm a respiratory student with Midlands Technical College. I'm here to be suctioning you today. If I could just get your name and date of birth, please. If the patient cannot talk, I would just check that wristband. It matches what I need, or they would just tell me. I would wash my hands, put on my gloves, put on my goggles to protect myself and the patient. I would go in depth on what I'd be doing today to the patient. So I'm going to be suctioning you today. I'm going to be trying to get some of that mucus and just nasty stuff out of your airways just so you can breathe a little bit better, okay? Great. As the patient is sitting here, I'm going to go ahead and hyperoxygenate. As that's going, I'm going to check my suction, turn it on. I'm gonna make sure it's hitting within that 120 to 150 range. If it goes a little bit over, that is okay. We wanna really make sure we get those secretions out. And it looks like it is. I'm gonna hook it to this and make sure it hits the same pressure without sticking it down the patient's. Okay, great. It is. Leave this hooked up while the hyperoxygenation is going. I'm going to grab this with my non-dominant hand. And the hyperoxygenation is over, so I explained to the patient what I'm about to do. Okay, so I'm gonna send this down, okay? You're gonna feel a big cough. Patient's coughing, I'm pulling back, and I am suctioning as I pull back. No more than 15 seconds. Okay, great. I will hyperoxygenate again. As that's happening, I'm listening to the patient's breath sounds. Okay, they still sound a little hoarse. So I'm going to do it one more time. Just again, waiting for this hyperoxygenation. Before we suction, it's good to do it for like 30 seconds, hyperoxygenation, and then after each suction, it's good to do it for a minute, just to make sure. Just gonna let that go for a second. Again, making sure the SATs are good, making sure they're not having any adverse reactions or anything like that, or we would stop and bag. And we're almost done, so I'm going to grab this again, non-dominant hand. Okay, that is done. I'm going to send this down. Okay, big cough for me. You have a big cough, I pull back a little bit and start suctioning on my way out. Again, no longer than 15 seconds. And again, before I do all this and start my procedure, it is a good thing to make sure that your catheter is 1/2 the size of the diameter of the ETT tube or less. We don't want to be taking all the volume away or not allowing them a breath while we're doing it. Okay, listening to those breath sounds one more time. It sounds like they have improved, which is a good sign. Patient's breathing better, SATs look a little bit better. Checking over the patient one more time, SATs, mechanical vent, make sure everything looks good. Closing my port, making sure it's closed, unhooking this, turning it off, wrapping it up. And if they did have thick secretions, we would just send this saline bullet down here to clean it out. And I'm just going to check that cuff pressure just to make sure it is within that 25-35 range, just to make sure. Okay, great, it is. And if this patient had secretions in their mouth or things of the sort, I would just take this Yonker, clean it out as best as I could, get those ones above that cuff as best as I could. Again, taking all my equipment that is disposable and tossing it away, taking off my gloves, sanitizing my hands, checking over the patient, making sure everything's great, leaving the BVM mask just in case anything happens future-wise. It's not bad to have right there. Leaving the room, charting what I've done. Did the patient take the procedure well? Yes. Things of that sort. And yeah, that's pretty much it.